please help spread the message of frequency-specific microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about frequency-specific microcurrent.
Because, and we were talking about this the other day, how much of our little show is unscripted. So there's like a constant blooper reel because it's not like we have a script to follow.
Say how much of it is unscripted is all of it.
All of it. Yeah. There is a general plan that I have in place, and you do your best every 7 days to blow it up.
In my defense, I don't know what your plan is.
And that's the great part about this.
So you put the train on the tracks, and then I just push the accelerator and we go, and it's not my fault.
Okay, we'll stick with that. But I think one of the reasons why it works and why there's so much transferability, is that a word, into everyday life is because we don't have a script with our clients and patients that walk in the door. Whether it's a new patient or somebody that you've seen for years, they're always going to present with something that's just a little not what you expected.
Always. Not what you expected. Patients don't come in with a script. They come in with, my right SI joint slips in and out. Really? That's interesting. And her history was 6 pages, and the medical term for it is tangential, which means it was like taking 400 ping pong balls and throwing them on a trampoline and then trying to follow all of them as they hit the walls and bounce back at you. It's like the history was really scattered. So the first thing I did was hand her the BIVSS. And then it turns out yesterday, part of her history was an abdominal surgery and for endometriosis. And so I treated scarring in the ureter, scarring in the kidney, sclerosis in the fat pad. And then she said, oh yeah, the surgery was because I had endometriosis, so it's everywhere. So I did scarring in the vagus, and her whole trunk opened up. Part of her history was reflux. So I had one machine going on just inflammation in the esophagus. And then I switched it to inflammation in the trachea because she keeps coughing. And she didn't cough until I said, hey, you notice you haven't coughed in the last 45 minutes. And then, of course, she coughed. And then I said, that cough didn't sound like the trachea. Did you have asthma? Oh, yeah, from the time I was 6 and through high school. High school, it got worse. So we did scarring in the bronchi.
Talk about the different types of cough for a second before you go further. Like, how would you differentiate between an asthmatic cough and?
That's a really good question. I have an N of 1 that taught me about that. And that was my cousin. He had reflux so bad that he slept sitting up in a recliner for 5 years. And he loved bread. So I did the cheek swab gene test. And of course, he was gluten sensitive, which is what gave him the reflux to begin with.
Sure.
So he came to Portland and I treated his esophagus. And it got rid of the pain in the esophagus, but it didn't get rid of the cough. And I went, esophagus, epiglottis, esophagus. He said, yeah, the cough is from the acid that comes up my esophagus. Above the epiglottis is the trachea. It's right there. That's the coughy part. So the cough is, it's like higher up. It's like right now, my voice is all gravelly. Because I choked on an apple. And so the trachea cough is up here. When she coughed after we did the trachea. It was deeper and almost gurgly. And that's what made me say, did you have asthma? So I had her take a deep breath, and it just brought on coughing fits that were down in her chest. Asthma's in the bronchi, and scarring in the bronchi, and had her inhale and cough. And I said, just don't try so hard.
Right.
Do less. So I did fibrosis in the bronchi, 51 in the bronchi, then scarring in the bronchi. And as she breathed, her chest started to expand. Now, we'd already done her psoas and the QLs, so the diaphragm would move. Now she had to open her chest up. So instead of being like this, she could be like that.
Right.
Can't be like that if your vagus nerve is scarred and if your bronchi are scarred. And who knew? I had no idea. I took a 6-page history and didn't find out she had asthma until scarring in the trachea didn't work to get rid of the cough.
You have a phrase for like flexibility, right? Ability of mind. And that's exactly what you have to have. And I remember hearing it day 2 of the very first core I went to, is to not get attached to the outcome. But it is so hard to not get attached to an outcome when you are a passionate practitioner. You want the favorable outcome and you want it quickly. And when you work with athletes, they want to be fixed yesterday, and they come in with a idea of what's going on. So I think it can be really challenging at times to have your client or your patient be flexible, that there could be something else here.
And that is mostly to save practitioners from becoming heartbroken.
Yeah.
So you treat every patient, at least I do, expecting a positive outcome. I look this lady right in the eye and say, nothing you have scares me. It's going to be okay.
Right.
Her pain level was a 2 or a 3. She's been incredibly stressed trying to do this estate thing for 12 years.
Mm-hmm.
And it's nothing you have scares me. It's going to be okay. However, at some point, for all patients, they have to pick up. Athletes are easy. They get broken a lot, but they have a mindset that is determined to recover. Civilian patients that come in, especially chronic pain patients that we treat on a regular basis, they come in and some of them aren't as attached to a positive outcome. They have lost hope. And you have to bring them along. So there's that slide that says it's the physician's job to hold the vision of the patient is healed until the patient can see it for themselves. I'll hold it for 6 visits.
Okay.
I'll hold it, and my sessions are now, new patient is 3 hours, each follow-up is 2 hours. So that's Monday, Tuesday, Thursday. I'll hold it until Thursday. Thursday afternoon, they have to pick it up. Usually by Tuesday afternoon, if they're going to, they've picked it up.
Right.
And the patient has to hold the vision with me. And then by Friday, when they leave, either with an exercise or diet or custom care or whatever. So with fibromyalgia patients, don't get attached to the outcome, because I really wanted to get all of my fibromyalgia patients better. And what I found out was, for some of them, if being in pain is the only power you have in your life, it is not reasonable to ask the patient to give that up.
Yeah.
It's just not reasonable. You let them, they'll come out. Back when I had a 3 times a week practice, they'd come and we'd get her down to a 2 or a 3, and then she wouldn't reschedule. And 4 months later, she'd come back at a 7, and we'd get her down to a too, but she'd never stay until it was done. The data shows that it takes 4 months for the neuroendocrine system itself and for fibromyalgia to go away. Fibromyalgia is the only power she had in her life. She didn't want to go to Aunt Martha's. She had to have a flare. Oh, I'm just not feeling well today. I just can't come. She couldn't say to Aunt Martha, I hate gatherings of 10 to 12 people. I will be happy to come and just have lunch with you, or we can go to coffee, but I just can't come today. There's just too many people. She couldn't say that, but being in pain is something you can use. So
I think the word power is one that has been like circulating since our last podcast, because about the word healer, right? And you didn't like that self-descripting phase. Like, I love the word facilitator, right? I am there to help guide people. My goal is to always have my mantra in life, my mission statement, if you will, is to get everybody to move better. However that looks. I love corrective exercise. I love finding the smallest movement patterns. I love finding the little jerks that don't want to get back online and try to get them online again. I want to champion that for that patient. And I think it comes down to giving them the power to have control over what they're doing. And like with athletes, and it's funny, the Olympics are on right now, right? And we're all watching these athletes. And one of the most irritating comments I find when the announcers are saying they're just freakishly strong, they've been an overnight sensation, they came out of the blue. No, that is the biggest insult you can say to these people who have worked tirelessly day in and day out. So
for years,
and have put their entire life's work into it, but we only see a snippet of what they're doing, that tip of the iceberg, right? We don't see anything underneath it. So for a patient to come to you and relinquish control and say, fix me or heal me, I think that is also a dangerous spot. This is a team, and you like to use the word synthesis, right? There are all these things that happen. In my opinion, it's not one person has the power and another person. There has to be a sharing of the power and a meeting of the minds with the flexibility of mind.
And the flexibility of mind, this reminds me of something that happened yesterday as well, is sometimes you're wrong. She has Achilles tendon partial tears, and then her legs were tight, especially up in the pectineus, the brevis, the adductors. So I was all about 81 and 10. So after I worked on her abdomen and her chest, I went from her abdomen down to her upper thigh, and 81 and 10 had been running for almost an hour. And the upper thigh was still really tight. And it's okay, it's not 81 and 10. Wait a minute, you had this huge surgery. So I had a towel under her low back. So I took the washcloth off her abdomen where I'd been treating the abdominal adhesions, took the washcloth, put it down at her right knee, and switched to scarring in the nerve and started peeling the nerve and the artery away from the pectineus, the brevis, the adductor magnus. And then I moved it and did the other side. And she said, whoa, what happened? And I said, remember that big surgery you had? There's a little hole in your pelvis where the femoral nerve artery and vein comes through. And if there's a bunch of blood in your abdomen during a surgery that they miss, it trickles down those little holes, and the tightness and restriction in your upper thighs isn't coming from your neck, like I told you yesterday. I lied. You got disc bulges in your neck, but that's not what's wrong with your legs. Feel this. Oh my God, they're soft. Yeah, I was wrong. It's scarring in the nerve. And that's why having FSM to be able to do that, there's no other way to know that's what was causing the tightness in her quads and her adductors. The only other thing it could be was scarring in the nerve.
Yeah.
And then when scarring in the nerve worked, then we knew that's what it was. It's so much fun.
How many people do you get that are attached to their diagnosis, that come to you and say, I have this and this, and I want you to fix that for me?
God and I have a deal. When I went back into practice and opened this clinic, I don't get like patients like that anymore. I've had two. One of them was last year, and I've got one right now. And there's a lot of central sensitization. It's not her fault. It's just neurology, and that's the power she has in her life, is being the way she is. She doesn't know that, and I wouldn't tell her that, because I could be wrong. Yeah, I don't get many now. When I was in general practice, I probably had more of them. 17 or 18 patients a day, all chronic pain patients.
I see a lot of people that are referrals from other physicians that say they have chronic tendinopathy, they have bursitis, they have torn labrums. So when somebody comes with a diagnosis or with imaging to back up what they believe, I also think it's important that we honor kind of the whole story. So yes, I understand you have, but let's talk about why the bursa got irritated. And they'll look at you like, what do you mean? The bursas don't get irritated for no reason. There's something mechanically that happened to irritate the bursa. My job is to figure out what that was and how we can fix it and how we can make sure it doesn't happen moving forward. And so I think something really simple, like just spreading it out, like, yes, the bursitis, and even just explaining bursitis means, and we take it for granted because we took medical terminology classes like 1,000 years ago. When you see the word or the suffix itis, it means inflammation. So it just means your bursa is irritated, it's inflamed, but let's figure out why. It surprises me how little lay people get that very kind of basic description.
They don't ask.
And I guess if the physician's only recourse is to inject it with a steroid, then who cares about explaining why the bursa is inflamed? Let's just give it a shot. I don't know.
I just had a meeting with an administrator at the chiropractic college. He's new. And we're talking about how physicians and patients interact and how he can influence that at the chiropractic college. He said, I have an osteopath in the Midwest where he came from. And he said, we spend 40 minutes on my history. Eye contact. What's going on? Oh, my low back hurts. Yeah, but what's your diet like? How much you're drinking? What kind of stress are you under? And the FSM practitioners are trained to do histories because the history changes what we do. But what this guy said was the osteopath asks all those questions, and just the fact that somebody will make eye contact with you, how's your life? What you doing? That helps the patient feel connected, but it also helps the practitioner, in this case, the osteopath, because when he puts his hands on the patient, he has a context for what he feels. The body will tell you what's going on with it. So somebody comes in and they're all jacked up and sympathetic dominant, anxious and agitated and in pain. So in our world, that means concussion and vagus. And then when you put your hands on them, they feel like you know them. I swear the history is the most important part of the interaction.
I agree. And the trust, right? Like I use the word power, but I use the word safety. and the secrets that people end up telling me because of the safety that is established in the room. So yes, safety in the fact that they are willing to disclose some parts of their history that they've maybe have never said out loud before, but you give them that platform to be able to disclose that, and to know that it's just like saying that there's never any dumb questions. There's never any dumb pieces of your history. There's nothing that is ever irrelevant. And the fact that somebody will say, and I'm sure you get this too, say, I don't know if this has anything to do with it, but, and I'll say, I'm going to stop you right there. The fact that you want to even bring it up means it absolutely has something to do with the history. So yes, tell me about the crazy time you fell off the monkey bars when you were 5, and you still have this very vivid memory about being in the hospital with that. Tell me about falling off the horse, slipping on the pool. Because we were able to connect so many dots, the history is such an important component. And to the practitioners that are listening, you're never done talking about the history on day 1. Like, that history will come up every single treatment. Or I've had people that I've seen for years, they'll be like, I can't believe I never told you this, but this happened to me. Do you think that has something to do with that? So you can take the most detailed history and have the most comprehensive exam, but you can only do what you know or what you are disclosed.
Yeah. And the body will sometimes tell you what the patient didn't.
Yes.
What is this thing from? Oh yeah, I forgot about that.
It was like when you treated me and you kept going through my ribs, and you're like, did you have asthma? I'm like, for a very short time. But again, it was something that has never bothered me. And as a long distance runner now, I never think about asthma.
Except your chest didn't go this way. You're breathing with your scalenes.
Yeah. Right.
Yeah.
Little fish.
Yeah.
But so you're right. Whatever the gaps are in the history, your exam and your treatment tend to bring you back to that area. I talk about the patient in Canada that I treated so long ago when I was new to all of this, who I had known had their gallbladder out, but I saw it very linearly, like, oh, maybe they have abdominal adhesions because of surgery. But I went in and I went out, and I didn't get to the, could she be reacting to the clips? There was this whole metal allergy component, toxicity. So I was close, I was hovering, but I just didn't really.
Metallic toxin is not the first thing that comes to mind. Scar tissue is the first thing that comes to mind.
And you get somewhere, right? You're like, absolutely, this softened and it helped, but it just didn't close it. It didn't get to, it's like that itch that you can finally scratch. You're just like, yes, that's it.
And then as you're treating them, there's somebody that said FSM is like truth serum.
Yeah.
So you're treating one thing and the endorphins go up and the patient gets all, and then, oh yeah, did I tell you about that time?
Yes. It's funny. I have a little story. So it's been almost a year since you treated me, and my running has been great. But my nose has been runny, and I have this weird cough after about 10 minutes. And it only happens when I run. I can say, now that's a good face. I've been like searching and asking, and all my physician friends are like, it sounds like postnasal drip. I'm like, but why does it only happen after about 10 minutes of running? No other activity, no other time. So brain bank, if you're listening and you have any suggestions. So I went to my doctor, whom I love, and she loves me. And I will come in with her and I'll say, doctor, I have a very strange postnasal drip, but it's not postnasal drip, but I get a runny nose and a cough, and it wouldn't bother most people, but I'm training for an important race and I hate this cough, and fix it. And so after a little bit of talking and laughing, she says, does your nose run when you have soup? And I said, I hate soup, but when I do have soup, you're right, my nose does run. She's like, yeah, that's easy. It's vasomotor rhinitis. It's not postnasal drip. I'm like, okay, how do we fix it? And I had to Google a little bit more about, I heard vaso, so I'm like, could it be vagal? And it is, it's an imbalance between the sympathetics and the parasympathetics, and it's an autonomic response that creates a runny nose. Why it happens when there's a bit of exercise, I'm guessing it's part of the nervous system after a certain point of time, but it is very interesting.
That's fascinating.
So I've
That is
been,
cool.
I know.
And the thing is, at about 10 minutes into running, your endorphins start to go up.
Right.
The other thing that happens is that your nasal passages and your bronchi get exposed to more air than they're used to, and they're being asked to expand.
Right.
I wonder if scarring in the vagus would do anything.
I'm going down that route myself, and
Mhm.
I do love scarring in the vagus. I love when I treat people with it. I feel very good. So typically, if I can snack off the current, that's usually indicative something.
Yeah, Sylvie says vaso is for vascular. Yeah, but the blood vessels don't do things by themselves. They're regulated by the sympathetics and the parasympathetics. At least the arteries are. So.
Yeah. So I've been treating and parasympathetics, and I will keep everybody updated who won't be able to sleep at night unless if I have a runny nose when I go running.
This actually explains every now and then I get this running nose. It drives me crazy. It's just clear. There's
Yeah, there's no mucus. I don't have allergies. I do the saline rinses. I've done antihistamines, but that explains why none of that has helped. But I've also been doing a lot of reading about nasal breathing. Dr. Andrew has a lot of great podcasts on box breathing, and the name is escaping me, where you take a deep breath in and then do an extra little sniff. It helps with vagal nerve stimulation. So I've been doing these breathing techniques while I'm running and just trying to breathe out of my nose, and that's been very helpful.
Okay.
So again, this is not being caught up with a diagnosis and having flexibility.
And also bringing information in from everywhere. That synergy, we don't work in a vacuum. One of the reasons the core seminar is 5 days and crazy is because of 27, almost 30 years of collecting information from people that know more than I do.
Yes.
And I put a little bit of this and a little bit of that.
We have a couple questions that are coming in.
Sure.
Let's check the one that just popped up here. It says, do you have any experience and insights into increased pain with barometric pressure changes?
Two things. Usually it's when the pressure goes from normal or high to low. So I can tell when it rains. So if you think of your body as being encased in 30 millimeters of air pressure, so that puts like a pressure here on your elbow and on your knee. And when the pressure drops, the little sleeve that's on your knee or your elbow gets looser. So maybe if the joint is inflamed, that will cause an increase in pain in a specific joint. The other thing is vestibular injuries. The endolymphatic sac has a little hole in the round window, usually, that makes it open to outside air pressure. So when the air pressure is high, the fluid that's inside the semicircular canals stays where it belongs. When the air pressure drops, the fluid in the semicircular canals changes, comes out, and your brain doesn't know where it is in space. So it tightens up your neck muscles to give it more information about where it is in space. That was what I was going to talk about last week. When I was in Austria on a Wednesday, I had severe disequilibrium, like all day. And so I just laid still. Ultimately, I ended up taking a whole bunch of medication to get it sorted out. The next day, there was a huge thunderstorm. So on Wednesday, the air pressure was dropping as the the low pressure front came through, and then the thunderstorm was Thursday, and then Friday it was over and I felt fine. What I found out is that I could run, can't remember who told me about it, might have been JJ, 40 and 44, quiet the inner ear, I know will soften the neck muscles. But I ran 124 and 44. So I wrote an inner ear program that lasts 2 hours where I ran quiet the activity of the inner ear to relax. And it helped, which was surprising. Yeah. And it was pretty scary. Yeah. Anybody that's treating a vestibular patient that has really tight neck muscles, when you're doing the supine cervical practicum, basically in somebody's neck, throw in 40 and 44 and see if that changes, quiet the inner ear, see if that changes the tone in the neck muscles. So those are the two things I can think of with increased pain and barometric pressure. That was the other thing that happened. When my ear went wonky, my body pain was like a 6. It was nasty.
I'm just thinking back in time when I moved from one province in Canada to another. When I moved to Calgary, much higher, drier altitude. For the first time, I had migraines.
Oops.
That was quite common because of the altitude, lower oxygen. Obviously, it's like altitude training, but obviously different than barometric pressure changes. But you do hear of people who do experience more joint pain when the weather changes. And
Yeah.
that is a pretty common.
So my best guess about that is that barometric pressure sleeve that we never think about because we're immersed in it. Does a fish know it's wet? And when the air pressure drops, if you have a knee that would be swollen if it wasn't in 30 millimeters of mercury, when the air pressure drops and you're at 27, then one joint can get more painful. That's how I think of it. I might be wrong, but
Then, yeah, for sure. And so what would you recommend people start off with frequency then?
oh, just treat the joint. The joint hurts and is swollen for a reason.
Yeah.
In the knee and the shoulder, start with the labrum and the meniscus and work outwards. Cartilage, basically the knee pain protocol.
Right. Yes.
Yeah. Even the capsule is driven by the inflammation in the synovium, which is inside the capsule, the cartilage.
Yeah.
Partial thickness tears in the ligaments, partial thickness tears in the tendons, partial thickness tears in the meniscus or the labrum.
Yeah. Periosteum.
Periosteum. Yeah. I'm just like, treat the joint.
Periosteum is such a pain driver.
Oh.
Yeah, that face is good where you're just like, why are you such a troublemaker?
Because the poor thing is just covered like a mat, like innervated felt with free nerve endings. Free nerve endings mean that they're not attached. It's not like a dermatomal nerve that goes from here to there. It's like astroturf with little nerves that sit up, just cover the top of the periosteum. So you bang your shin on the coffee table and it hurts like crazy because you just smacked the periosteum and you smacked a bunch of little nerves.
Yeah. And that is why little fractures hurt so much. Or sprains and strains can be more painful because of the pulling off of the periosteum. Shin splints.
It's not just the torn tendons, it's the periosteum. As the tendon is tearing away from the bone, it's tearing the periosteum.
Let's talk about shin splints for a quick second, because I find that we always say you want to get the patient out of pain as quickly as possible. So treating torn and broken in the periosteum is absolutely going to help the pain. But the shin splint did not, again, happen from outer space. The periosteum didn't have all this traumatic pull on it because the tissue was healthy.
Exactly as the tib posterior, the tib anterior working so hard.
And people want the really quick fix. So I always get, what kind of shoes should I buy? I'm like, it would be great if a shoe would fix shin splints, but that's not the case. And there's better shoes for somebody. And so when we do gait analysis, you can see if they pronate. But for the most part, like, we need something a little more cushiony on the heel. It's going to give us a little bit more of that propulsive movement. So we're not jamming our heels around so much. We're not getting so much dorsiflexion, plantar flexion. We need some movement with the ankle. So you're looking at the posterior leg, hamstring, glute.
Also pronation control.
Yeah.
It's like almost always, and I have a lot less experience with this than you do, but almost always, if you look at dysfunction in the shin splints, ankle, knee, it's overpronating.
Yeah.
It's just big. There you go.
And unfortunately, you need different shoes for different surfaces. So if you are trail running, you need something that is very neutral so that you can feel where your foot is on the unstable surface. If you're just road running or track running, it's very monotonous for the hip, knee, ankle complex. And that can be good and it can be bad, but there's so much more information when you are walking or hiking on an unstable surface. So you need to have
Uneven.
Yeah, that needs to give your brain that feedback, and that proprioception on our balance just really takes a dive as we get older. So we need to make sure we're always challenging our balance.
And this is something I explained to the patient this week. She's 72 and she's been having more and more physical problems in the last 10 years or so. And a lot of them relate to balance. She said, my balance is just awful. Some of it was the adhesions in the nerves in her adductors. I said, but part of it is once you're past, let's say 50, starts when you're 40, but once you're past 50, the fast twitch muscles in your muscles are replaced by slow twitch. You don't have, part of the magic of balance is fast twitch muscles. You start to lose your balance and the fast twitch muscles go, yep, nope, and your balance just jumps back to neutral. When you're 70, I have very little in the way of fast twitch muscles. That's just data. That's real. I can't train them. I can't make them happen. I can't play racquetball anymore. I tried. That was hilarious. Used to be great at racquetball. Now it's, wait, where'd it go? So the patient's age, that little factoid, it's like she was frightened about her balance. Maybe I had a stroke in my cerebellum. She has an MRI of her brain. No, you didn't have a stroke. Fast twitch versus slow twitch. Oh, she didn't know that was a thing. It's expectations and it's a management problem.
I was just going to interrupt and say that, but I wasn't sure if that's where you were going.
No, that's it.
Yeah, and there always is a management problem. We're always managing something, right? So I'll always say there's the short-term play and then there's the long-term play. Short-term gets you out of pain, get the inflammation down, get you moving a little bit better. But long-term, we have to maintain this, whether it is the chronic wear and tear for somebody who's running or working out all the time or is a professional athlete or somebody who's aging. Like, we're always managing something. And I think that's why we're so lucky that we have custom cares that we can help people manage something. And again, it goes back to the power. Like, you take your power back when you have tools to help somebody recover.
Speaking of managing and recovering, takes me up to Dana's question. It was the very first one at the top.
Oh.
I've used FSM to recover from having to pull an all-nighter. If one should need to work all night, which I can never do, because is there anything you would recommend before or during as opposed to support after the fact? Sleep is how you detoxify your brain, and deep sleep is how you make growth hormone. 85% of growth hormone in an adult is made during deep sleep. You pull an all-nighter and you don't get growth hormone. Growth hormone in an adult facilitates the transport of amino acids across the cell wall to repair the muscles. You have two things after you pulled an all-nighter. Number one, you need a nap. So you have to get some sleep.
Mm-hmm.
And it's very likely if you have a little ring on, it will show you that you fall into deep sleep almost immediately, because what you're dealing with after an all-nighter is foggy brain, a little bit of nausea, and body pain. You just ache all over. Oh, I was sitting all night and I was in a bad posture. No, you didn't get any growth hormone tonight. The reason that you don't have body pain from walking around, carrying groceries, lifting your briefcase, doing whatever, is that every night you make growth hormone and you repair the muscles that you injured during the day. For an all-nighter, afterwards, I'd run concussion in Vegas. During the challenge that I have about Dana about running anything during is running anything that I can think of, like the concussion protocol, or 40 and 90, or 40 and 89, or quiet the anything we would run during would put you to sleep.
What about running brain fog before? I find brain fog very stimulating and excitatory, but not twitchy or spasmodic, but just let's go.
Okay, that might help.
It's the only thing. I love brain fog.
Brain fog is my friend.
Think about even when we're at the advanced and we're literally drinking the Kool-Aid. I'm just like, let's keep learning.
Next week and the week after, my project for today before Kevin and I go home is to send out an email to everybody, and that includes all of you that are listening, about case presentations for the symposium. We have guest speakers for the symposium, but the most important part of the symposium is practitioners sharing with other practitioners their case reports. And it doesn't have to be anything exotic or spectacular. Just the patient had this and I did that, and this is what happened. And that's a case report. It's 20 slides. And that's my favorite part, is choosing the case reports. And if we don't have enough speaker slots, you can make a poster and we'll put them up on the walls in the ballroom. We'll be back in Arizona in March. I'm so excited. Hope that helped, Dana.
There's another one, Louise, popped up on the bottom.
Okay.
Let's see, hang on.
Systolic is 20 degrees higher on the right arm. Maybe that's why they always take it on the left.
Do you want to read the question for the pod people?
Yeah, BP systolic consistently is 20 millimeters of mercury higher on the right arm, 122 on the left versus 142 on the right. What structure could cause that? I love the fact that you asked that.
The structure, yeah.
Yep, you get extra points. If I could throw chocolate through the computer, I would do that. She did have shoulder surgery 3 years ago. The systolic is on the side of the operated healed shoulder. Any suggestions? There's two things that occur to me. The first thing is, this is way outside my scope, and she needs to see a cardiologist to make sure that it's not cardiac. But the other thing that could be scar tissue in the brachial artery. So when you take blood pressure, you compress the brachial artery until the pulse goes away, and then you gradually release it. And blood pressure is, when the pulse comes back, systolic and diastolic. And I would try scarring in the brachial artery. If you think about what they did to the shoulder, if it's laparoscopic, or if it was an open procedure. And Louise, you also get extra points because you take the blood pressure bilaterally. That's just so cool. The only thing I can think of that's not cardiac, that is local, is scarring or fibrosis in the artery. That would increase the pressure that it takes to close it shut and then release it, maybe. That's a wild guess. Okay, she is getting a diagnostic vascular CT with dye. All right, so you're covering all the bases. I'd still treat scarring in the artery, or fibrosis in the artery.
And between the two, do you normally start with one versus the other, scarring versus fibrosis?
I have become like a 13 sort of person.
Yeah.
Fibrosis I use on soft webby tissue and on kids, maybe.
I like it on the capsule.
Yeah, because it's just fibrosis. Have a list in there someplace, because you keep talking about the list that we don't get to, and I haven't seen you look down at a list at all. Do we not have a list this week?
Oh, you don't want to see what's out of the shot with all the papers right now, because it is a scary.
I have to give you, we have 7 minutes left, so I have to give you at least a shot at the list, because I always feel so bad when you say, we didn't get to my list.
No, the list is a continual growing expansion. It's like a life force all to its own.
Right.
It always works. And there's always something that I want to try to tie in and add so that the podcast can have some sort of theme. But I feel so sorry for Kevin that has to put titles on these, because it's not like we stick to a topic like low back pain or joint pain, because it's never just like that. And I had an email last week that said, could you just give me the recipe for standardized low back pain?
No.
And I said, I would love to. And if I could come up with a standardized list for low back pain, I would be charging you a lot more, because it would be so nice if it was just that easy.
I have been told that I need to do a webinar on low back pain, neck pain, and I can't remember about the other one, but low back pain and neck pain, maybe nerve pain too. But low back pain, one of the challenges, the reason we do the lumbar practicum last is the pain generators in the low back are the facets. So if the pain is worse when you lean back, it's facets. If its pain is worse when you lean forward, it's probably a disc. If the pain is both, there are all those visceral causes of low back pain. And in almost every class, it's the psoas. And if you look at the pain diagram for the psoas, it is the low back. And it's like 100% of trigger points in the psoas are scarring in the ureter. And almost always there's scarring in the kidneys, sclerosis in the fat pad, and then scarring down in the bladder. And that's low back pain. The low back pain protocol on the custom care is just facets and discs.
Right. And it's nice that it's there, and it's a great tool to have if you don't really know what's going on, and it will help because it is all encompassing and you've covered all your bases. But as we know, for true healing and to expedite results, you have to be as specific as possible. So the low back pain is a great start, but once you can differentiate between if you're dealing with a disc and a facet, and like even what part of the disc, right? Like a young athlete that has disc pain, I'm going more to torn and broken in the annulus. Like they're young and it's just a compressive shearing that's happening with that disc. It doesn't need to sit through the whole crazy low back pain protocol.
Yeah. And if it's the psoas, you have compression that causes both facet and disc pain. So you can take care of the low back pain symptomatically by treating facets and discs, because a lot of times they go together because of the compression.
Yeah.
But torn and broken in the annulus is what I use to treat the disc in the low back pain protocol.
I've been treating my squished disc I have an inversion table, so I get to hang upside down, but I run torn and broken in the annulus while I hang upside down. So there's that traction. With your low back pain webinar, that'll be I think you should do that. And I think we could maybe replace the podcast here and there with you just putting on the webinar, because
okay.
Maybe I'll give you the date when I'm going to be gone, and then you can.
Oh, cool.
There's a Wednesday in August that I'm on a plane, but I think that'd be a great idea to be specific with a body part. I would be happy to do an extremity, like a shoulder or a hip, or
Fun.
yeah, maybe we could spend an hour and just really be specific and have the train on a track going to a destination with no stops.
Yes. And we will end up with a webinar library.
Yeah, I think that's fantastic. I think so much has changed in the last few years with how we see and treat. So maybe these webinars can be helpful for the people that have taken the course like 10 years ago.
Yeah. I was talking to somebody that took the course in 2008. Oh, my dear.
I think that was my original course, and I could not imagine if I had just left my FSM education in 2008 where I would be.
Yeah, I agree.
Much fun.
We've done so much in the last, I don't think I learned how to teach it until about 5 years ago.
That gives me some hope then.
Oh, yeah.
That I don't need to be where I need to be. But I'm going to be in Portland at the beautiful Troutdale Clinic in November. I'm so excited to be there. That facility is just a beautiful space. It's like a vortex of knowledge all in one location.
And comfort.
Yeah.
You walk in the front door and there's that sign that says there is hope here.
Yeah.
There's not certainty, but there's hope.
Yes. And to bring that to people is such an important, we have these beautiful little words, power, hope, safety. If we can bring that into our treatments, I think we're far ahead of the game.
Oh, but Debbie's coming to Troutdale. That'll be so much fun.
Yes.
Yay.
Yes, everybody come. It's going to be a lot of fun. Kevin, you talked about 0 barefoot shoes. I just want to say really quickly, there's so many different types of shoes. The 0 drop and barefoot shoes can be great. I love running in really thick shoes on the road, and I love running barefoot on the sand. And I think there's just a space for all of that in between. And my cautionary tale is if you are running in thick shoes, don't just go to a 0 drop or barefoot shoe and run 10 miles in that, because it takes a lot of time to transfer from one to the other. So go slow with your transitions. I'm sure you get asked the question all the time, what kind of mattress should I sleep on? Or what kind of pillow should I have? The one that doesn't make you hurt.
Yes.
So only you can decide that. I feel like the Smokey the Bear. Only you can prevent forest fires.
Exactly.
True. And I have an alarm going off, so apparently it's
4 o'clock.
And yet really quickly, Monique said case reports for the conference. Yes, like these case reports.
Okay, case reports for the conference. So the symposium, we have guest speakers that come. Juliana Mortensen is getting invited back. Neil Nathan can't come, but we have guest speakers that talk about general science and resonance and topics. But the most important part about the symposium is the case reports. So it's 30 minutes, and the structure is some history about either the patient or the condition, and then what you treated and how it turned out with some data, either range of motion or x-rays or pain level or bleeding or something that changed. And it's 30-minute slot. My recommendation for new speakers is 20 to 23 slides in 30 minutes, because most people get hung up talking longer than they thought they would, especially at the beginning, so you get rushed at the end. So 20 PowerPoint slides in 30 minutes. And what did you treat? So Sandra last year was ALS. Who would have thought? I've got a case this year of SPG7, which nobody's heard of, spinal spasticity gene, and it just uterine fibroids, kidney stones, asthma, torn meniscus. David Murphy from Ireland came with a pre and post MRI where he rebuilt the cartilage in somebody's knee, like it wasn't there. And then 3 months later, it was there. That's cool.
It's so much fun. And just when you think, oh, I don't treat kidneys, I shouldn't go to this. No, you have to go to all of them, because I had that mentality with Mary Ellen Chalmers. It was, I thought,
Yes.
I'm not a dentist. I don't work in people's mouths. But guess what? The jaw is connected to the neck and the neck is connected to the shoulders, and everything is everything. And it's changed the way I see head and neck pain.
And the facial nerve and the trigeminal nerve and the pain pathways and how they interact with the neck and the brain and the face. I see her slides in my head. Yeah. And she'll be back too. Yay.
All right. Now we're officially over. That's okay. We have next week to catch up. All right, everybody. Thanks for coming. Keep the questions coming. Emailing them is great too, so we can add them to the list before the podcast if you can't join us live. So
sounds good.
All right, everybody.
See you next week. Bye.
The Frequency-Specific Microcurrent podcast has been produced by Frequency-Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.